Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is May 28, 2025. This video is on a recent JAMA article published online on May 14, 2025, titled Spironolactone versus Amiloride for Resistant Hypertension. There was an accompanying editorial by Robert Brook, Jody Cohen, and Sanjay Rajgopalan. Resistant hypertension, that's a systolic blood pressure equal to or greater than 130 millimeters of mercury, despite 3-drug regimen, including ARBs, calcium channel blockers, and thiazides, were included in the study. Spironolactone is the standard fourth-line agent, but has risks, including gynecomastia and hyperkalemia. Amiloride is a potassium-sparing diuretic with fewer antiandrogenic effects. The study design, prospective, open-label, blinded, endpoint randomized controlled trial at 14 sites in South Korea. The sample size was 118 patients with uncontrolled home systolic blood pressure equal to or greater than 130 millimeters of mercury. After a 4-week run-in on triple therapy, they randomized 1:1 to spironolactone, starting dose 12.5 and increased to 25 milligrams a day, or amiloride from 5 to 10 milligrams per day. The primary endpoint was home systolic blood pressure change at 12 weeks. Secondary endpoints, systolic blood pressure less than 130 millimeters of mercury at home or office, and safety endpoints including potassium and other adverse events. What did they find? Amiloride reduced blood pressure by 13.6 millimeters of mercury, spironolactone by 14.7 millimeters of mercury. Non-inferiority margin, 4.4 millimeters of mercury was met. Amiloride was non-inferior. Blood pressure target less than 130 millimeters of mercury was achieved in 60% of patients in both groups. Safety and tolerability, no gynecomastia. 1 case of hyperkalemia in the amiloride group. Adherence was excellent, 80% in all, but 1 subject per group. The limitation, short 12-week follow-up, low-dose hydrochlorothiazide instead of chlorothalidone was used for treatment. Excluded EGFR patients of less than 50, not generalizable to CKD. All South Korean cohort, limited ethnic diversity. Insight, amiloride is a viable, safer alternative when spironolactone is not tolerated. The accompanying editorial commented that this 12-week randomized controlled trial compared low-dose spironolactone versus amiloride. Amiloride was non-inferior, few adverse events, both drugs were well tolerated and good adherence. The editorial critique said there was submaximal background therapy. Hydrochlorothiazide was 12.5 milligrams, may have inflated the systolic blood pressure baseline. Titration was not protocolized. Majority remained on lower doses at week 12. No placebo arm. Actual blood pressure lowering effect was likely 10 millimeters of mercury after adjustment. And they also commented that spironolactone may offer cardiovascular benefits via the mineralocorticoid blockade not matched by amiloride. Key takeaway, amiloride is a viable alternative if spironolactone is not tolerated, but spironolactone remains first line. This is an infographic of the study just discussed. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.